December 4th, 2024, Midtown Manhattan, early morning. Brian Thompson, the CEO of United Healthcare, is shot and killed.
Got a male shot outside of the hotel. No prep description at this time.
We have some breaking news. CNN has obtained new surveillance video from the fatal shooting of the United Healthcare CEO. And we do want to warn you that the video is, of course, disturbing.
And according to reports, words had been written onto the bullets: deny, depose, defend. A phrase many saw as a direct reference to the way health insurance companies are accused of protecting profits, rejecting claims, dragging people through disputes, and shielding themselves from responsibility. But what happened next caught the media off guard. Instead of a wave of sympathy, America erupted into something else entirely: a massive public conversation about the state of healthcare in the United States. Because beneath the headlines was a much bigger question. How did the richest country in the world end up with a healthcare system this expensive and this broken? Today, the US spends more on healthcare than any country on earth, and by a huge margin. Americans pay more, visit doctors less, and still have a lower life expectancy than people in comparable wealthy nations. So what exactly went wrong? This is the story of US healthcare, an American sickness. Every year, the United States spends nearly $5 trillion on healthcare. That is close to 18% of total GDP. And for all that money, the return is shockingly poor. Among 10 high-income countries, the US ranks at or near the bottom when it comes to outcomes and access. And from a financial perspective alone, the system is wildly inefficient. Some estimates suggest that improving it could save Americans nearly $2.5 trillion. That is not a minor fix. That is a complete systemic failure. To understand why healthcare in America costs so much and delivers so little, we need to break the system into three major parts: insurance, providers, and pharma. Let's start with insurance. About 92% of Americans have some kind of health insurance. Usually that comes from one of three places: employer-sponsored plans, government programs, or individual coverage. Now, unlike many developed countries, Americans don't just get assigned one national system. They often choose between multiple insurers. And on paper, that sounds like a good thing. More choice, more competition, more consumer power. But in reality, that choice creates chaos. Because every insurer can have different billing codes, different reimbursement systems, different doctor networks, different pharmacy networks, different rules for prior authorization, different claims processes, different PBM arrangements. And the result is that healthcare becomes less about medicine and more about paperwork. According to the American Hospital Association, roughly 40% of hospital expenses are tied to administration. Not treatment, not surgery, not patient care. Administration. And when researchers compare the US to other developed countries, around 30% of the extra cost can be traced directly to administrative overhead caused by the insurance system itself. But the money is only half the story. The real issue is what happens to patients. In the US, insurers deny around 16% of claims overall. Some companies deny much more. United Healthcare and Medica, for example, have been reported at 32% and 27%, respectively. Think about what that means. A doctor says a patient needs care, and nearly 1 out of every 5 times, an insurance company says no. At that point, the patient is left with 2 options: pay out of pocket or walk away from treatment. And if they pay, the consequences can be devastating. Medical costs in America are so extreme that around 67% of bankruptcies are linked to healthcare-related expenses. Meanwhile, nearly 40% of Americans have either delayed care themselves or know a family member who has, because of cost. Insurers say these denials help control spending and stop unnecessary treatments. And yes, in some cases, that argument has some truth to it. But here is the problem. Denials are rising. From 2022 to 2023, denials increased by 20% for commercial claims and 56% for Medicare Advantage claims. And there is a reason companies can do this. Almost nobody appeals. Less than 1% of denied claims are challenged, not because people suddenly agree they did not need care, but because appealing takes time, money, energy, and often legal or bureaucratic knowledge most patients simply do not have. And when denials are appealed, the numbers are brutal. About 75% of Medicare Advantage denials that were challenged ended up being overturned. That is around 216,000 cases. In other words, a huge number of those original denials should never have happened in the first place. The incentives here are obvious. Insurance companies benefit when they deny as much care as they can get away with. And this is not some abstract financial product. This is healthcare. These decisions happen when people are sick, scared, and vulnerable. And it gets worse. Enter prior authorization. For certain treatments, doctors cannot move forward until the insurance company gives permission. In theory, this is supposed to prevent unnecessary care. In practice, it often delays treatment that patients urgently need. For example, 30% of radiation oncologists say they have had a patient either end up in the emergency room or suffer permanent harm because of prior authorization delays. Read that again. Not because the medicine did not exist, not because the doctor did not know what to do, because the paperwork wasn't approved in time. And the review process can be absurd. In oncology, doctors often have to justify their treatment plan to a so-called peer reviewer from the insurance company. But about 35% of those peers are not even oncologists. Across all specialties, physicians say those reviewers are appropriately qualified only about 15% of the time. So why are insurers able to operate like this? A big part of the answer is concentration. About 73% of commercial markets, 71% of Medicare Advantage markets, and 90% of ACA markets are considered highly concentrated. Some people defend that by saying larger insurers should have more bargaining power and lower administrative burden. When insurers merge and markets consolidate, premiums usually go up. Studies of deals involving companies like Aetna, Prudential, United Health, Sierra, and others repeatedly point in the same direction. Consolidation does not lower prices for consumers. It strengthens the insurer and boosts profits. And breaking into this market is incredibly difficult. Regulation is heavy, scale matters, and anti-competitive behavior makes it hard for new players to survive. Then came vertical integration. In 2010, the Affordable Care Act limited how much profit insurers could keep by requiring them to spend 80% to 85% of premium revenue on medical care. But in response, insurers started looking for profits elsewhere, especially by buying deeper into the healthcare ecosystem itself. United Health, for example, directly employs around 10,000 doctors and has business ties to another 80,000. Together, that is roughly 10% of all physicians in America. And while vertical integration is often sold as efficiency, it also concentrates even more power into the hands of the same companies that already control access to care. That is the core issue with the insurance side of the system. When insurers win, patients do not necessarily win. The system is too complicated, too concentrated, and too distorted to consistently lower costs or improve outcomes. But insurance is not the only problem. Providers are part of this too. Let's talk about doctors. This may be uncomfortable to hear, but physicians in the US are one reason healthcare costs are so high. American doctors are paid substantially more than doctors in many other countries. There are several reasons for that. But one of the biggest is simple. There are not enough of them. The US has about 2.6 practicing physicians per 1,000 people. The OECD average is 3.7. So why does the US have fewer doctors? Because supply was constrained. Roughly 2 decades ago, the American Medical Association pushed to reduce medical school expansion, cap federal residency funding, and cut residency positions, partly out of concern that there could be too many doctors. The result was extraordinary. The number of medical school graduates in 1980 was about the same as in 2005, even though the US population had increased by around 30%. Of course, this is not just about individual doctors. Hospital systems, corporate groups, and investors also helped create the mess we have now, because just like insurance, healthcare delivery has become heavily consolidated. Independent physicians often struggle to survive under the administrative weight of the American system. Joining a larger network can be the only practical way to avoid being crushed by billing complexity and compliance burdens. Over the last 2 decades, the US has seen around 1,000 mergers among its roughly 5,000 hospitals. Today, about 3 out of 4 doctors work for either a hospital or a corporate group. A lot of that consolidation has involved private equity. Now, supporters of private equity will say it improves efficiency and lowers internal costs. In theory, maybe that should mean lower prices for patients. But patients are not normal consumers in a normal market. They are often captive. They do not shop around during emergencies. They do not negotiate from a position of strength. And when private equity controls enough of a local market, the incentives become obvious. Recent research found that when PE firms control more than 30% of a market, prices rise meaningfully. One study found increases of 18% in gastroenterology, 16% in OB/GYN, and 13% in dermatology. A particularly aggressive example was US Anesthesia Partners. After building major market share in Denver, the company was reported to charge reimbursement rates 30% to 40% higher than competing groups. In other words, once they controlled enough anesthesiologists, insurers, and patients had little choice but to pay what they demanded. And the cruelest part? The quality of care does not improve. A University of Chicago study found that private equity ownership of nursing homes was linked to a 10% increase in short-term mortality. A Harvard study found that when hospitals were acquired by PE firms, complications rose by 25% and bloodstream infections by 38%. If your business model is built around squeezing more revenue out of each patient while servicing debt and maximizing returns, corners will eventually get cut. And greed is not limited to private equity. Even nonprofit hospitals can behave like giant profit machines. Take UPMC. Its former CEO at a nonprofit hospital system made nearly $13 million in fiscal year 2022. So on the provider side, the pattern looks familiar. Limit supply, consolidate power, raise prices, and detach financial success from actual patient outcomes. And then we get to the final pillar, pharma. The United States makes up around 44% of the global pharmaceutical market, more than $600 billion in spending per person. Americans spend more on prescription drugs than anyone else in the world. In fact, they spend nearly 50% more than Germany, the next highest country. Are Americans getting better drugs? No. In many cases, they are getting the exact same drugs, just at much higher prices. When Bloomberg looked at 8 of the top-selling drugs in the United States, it found that even after discounts, all but 1 were still more expensive in America than in every other major country studied, sometimes by a lot. Take Gleevec, a drug used to treat chronic myeloid leukemia. In the US, it costs roughly $90,000 more per year than the average price in the rest of the world. And the insanity does not stop there. Even inside the United States, people can pay wildly different prices for the same drug, depending on what plan they have and where they live. A generic version of Zytiga, used in prostate cancer treatment, has more than 2,200 different prices across Medicare plans. In one part of Michigan, it might cost around $815. In another nearby region, that number can jump to almost $3,400. Drug companies often defend these prices by pointing to R&D. And yes, research is expensive. It often represents 20% to 40% of revenue. and most drug ideas fail. But that explanation only goes so far, because these same companies still post strong margins, strong returns, and somehow manage to sell those same drugs to other countries for far less. The biggest reason prices remain so high in the US is that, unlike most developed countries, the American government historically has not negotiated directly with pharmaceutical companies at full scale. The Medicare non-interference clause limited that power, which means the largest market in the world has not fully used its own leverage. And when one program like Medicaid caps prices in one place, pharma can simply push the shortfall onto other payers. But the issue with pharma is not just price, it is ethics. In 2014, the Open Payments Database was launched to reveal financial relationships between drug companies and healthcare providers. And that raises an uncomfortable but necessary question. Why are pharma companies paying doctors? The answer is obvious. Because doctors decide what gets prescribed, and prescriptions drive revenue. The more influence a company has over physicians, the more likely those physicians are to recommend that company's drug. Sometimes that influence comes in legal forms: consulting arrangements, speaker fees, research funding. Sometimes it crosses the line into illegal kickbacks, and the scale has grown massively. Since 2014, reported payments from pharma to providers have increased from $6.5 billion to $12.8 billion. Not all of that is illegal, but a huge amount of it lives in a gray zone that should make patients very uncomfortable. Because how do you know a prescription is based purely on medical judgment when the doctor receives money, prestige, consulting fees, or research support from the company making the drug? And this is not theoretical. There are countless examples of misconduct, from Novartis to Pfizer to Purdue Pharma and the opioid disaster. This is not just a financial scandal, it is a human one. So yes, pharma is broken too. Americans often pay dramatically more for the same medications, and in some cases cannot even be fully confident they are being prescribed them for the right reasons. And the truth is, this still does not cover everything. We have not even touched PBMs, hidden fees, price opacity, Medicare Advantage distortions, collapsing rural hospitals, or surprise billing. That is how massive this system is, and that is how tangled it has become. But one conclusion keeps surfacing again and again. The complexity is not producing better healthcare. It is producing waste, inefficiency, and bad outcomes. Now, to be fair, if you are wealthy, well-insured, and financially secure, the US healthcare system can be phenomenal. It has cutting-edge technology, elite facilities, incredible specialists, and some of the best doctors in the world. But there is a catch. You have to be able to afford it. American healthcare is like a Lamborghini. Yes, it is powerful. Yes, it can be world-class. But what kind of society builds a system where the only vehicle most people can access is effectively a luxury product? Medicine is not just another business. This is not fast food. It is not tire repair. It is not a premium lifestyle upgrade. It is life and death. And even if you oppose a government-run model, you still have to confront the obvious. Many countries with cheaper, broader, more universal systems produce better outcomes than the United States does right now. That is what makes this so damning. America does not just have the most expensive healthcare system in the world. It has one of the worst performing systems relative to what it spends. And this is not about ideology. You do not have to be socialist to see the problem. You do not have to hate markets. You do not have to oppose private enterprise. You just have to care about outcomes. You just have to care about ethics. You just have to care whether the system actually works. And by that standard, this system is a disaster. It is a system that can delay treatment for a sick child because an insurer has not approved it yet. A system that can hit a recovering patient with a bill they can never realistically pay back. A system where prices keep rising, outcomes keep slipping, and the core incentives remain broken. So the question is unavoidable. Is greed always good? Thanks for watching. Thanks.